Imagine an emergency room. Like the double doors just fly open.
Right.
A 5-year-old kid is rushed in. They're pale, lethargic. Skin is totally cold to the touch. The pulse is racing, just this frantic, weak flutter.
The blood pressure is dropping fast.
Exactly, it's plummeting. And if you are the doctor in that room, standing over that child, you don't immediately grab a scalpel, you know?
No, absolutely not.
You don't grab a defibrillator either. Your first, most critical tool to pull that kid back from the brink of death is, well, it's a calculator.
Which sounds crazy, right?
It does. Because in that moment, the line between saving a life and accidentally, overwhelming a crashing system, it all comes down to arithmetic.
Precision.
Right. Highly specific physiological math.
Milliliters and fractions.
The margin for error in pediatric fluid resuscitation is it's incredibly small. You're basically trying to manually take over the fluid dynamics of a complex biological organism.
An organism that has completely lost its ability to regulate itself.
So, welcome to the deep dive. Today, we are undertaking a pretty massive mission. We've got this incredibly dense clinical intelligence.
The kind of stuff pediatricians rely on every day.
Right, the high-level analysis you'd find in something like the Nelson textbook of pediatrics.
Yeah.
And we are going to tear it open.
Unpack it all.
Yeah, we're going to explore the hidden mechanics of human fluid management for you. But the really wild part,
Here we go.
to understand how to save a child in catastrophic shock, we first have to understand this completely different, seemingly mundane issue.
Bedwetting.
Bedwetting. It's so weird.
It sounds like a totally bizarre juxtaposition, like the high-stakes trauma bay versus, a frustrating night changing sheets in a kid's bedroom.
Yeah, totally different world.
But biology, it doesn't really categorize itself the way we do.
It's all connected, so we are going to bridge that gap today. By the end of this deep dive, you're going to understand a really unexpected mechanical cause of bedwetting.
Which is fascinating on its own.
Oh, it really is. And you're also going to be able to visualize the microscopic pumps running inside your own kidneys right now.
The cellular factories.
Right. And maybe most incredibly, you'll step into the shoes of that ER doctor and learn the exact math formulas they use in real time to save a life.
It's intense stuff.
Okay, let's unpack this. Let's start with the bedroom before we hit the emergency room. Let's talk about enuresis.
Let's define the territory first, I think.
Yeah, good idea.
So the term enuresis, it's derived from the Greek word onurion.
Which means?
It simply translates to void.
To void. Okay, pretty straightforward.
Linguistically, sure, but the clinical definition is anything but simple.
Yeah, when I started looking into the diagnostic criteria for this, I was honestly struck by how strict it is.
It's very specific.
Right. You aren't just talking about a toddler having a random accident because they drank too much apple juice before bed.
Far from it. The clinical threshold is actually really rigorous.
Walk me through it.
Well, to formally diagnose pediatric enuresis, the involuntary or sometimes voluntary voiding of urine into clothes or the bed, it has to happen at a specific frequency.
Which is?
At least twice a week.
Twice a week? Wow.
Right. And it doesn't stop there. It must persist at that exact frequency for a minimum of 3 consecutive months.
3 months?
Yeah, a full quarter of a year.
Okay, put yourself in the shoes of a parent for a second here. Like week 1, there are 2 accidents.
You're annoyed, but you wash the sheets.
Exactly. You figure, oh, it's a fluke. But then week 2, 3 accidents. Week 4, week 8, week 12.
It becomes a massive burden.
That is a grueling, exhausting period for a family. And that's all before it even officially hits the radar as a clinical diagnosis.
The psychological toll on both the kid and the family during that waiting period can be immense. It really can.
I can't even imagine. Why make them wait that long?
Well, that duration is necessary for a pediatrician to differentiate between a temporary stress response.
Like what? Like a regression?
Exactly. A regression because of a new baby in the house, or maybe a move to a new school. Those things cause temporary accidents.
Oh, I see. So the 3 months rules out the temporary stuff.
Right. It separates behavioral or stress responses from a deeply ingrained physiological or neurological issue.
That makes a lot of sense. And there's another really crucial factor in the criteria here. The child has to be older than 5 years.
Yes, age 5 is the clinical baseline.
So let me get this straight. If I have a 4-year-old who is wetting the bed 3 times a week for 6 months,
Still doesn't qualify.
it does not qualify as clinical enuresis.
Based on standard pediatric guidelines, no, it doesn't.
That's wild. Why?
The underlying neurology there is actually really fascinating. The medical community sets that threshold strictly at greater than 5 years of age because, well, they acknowledge that the brain-bladder connection is a massive developmental hurdle.
It takes time to build.
A lot of time. A 4-year-old having accidents is considered to be completely within the window of normal, albeit maybe slightly delayed, physiological development.
I really want to dig into that brain-bladder connection because as adults, we completely take it for granted.
Oh, entirely.
You feel the urge, you go to the bathroom, simple. But for a child, they have to physically grow the actual wiring to make that happen.
Just consider the sheer complexity of what has to occur. So first, the bladder fills with fluid.
Okay, it's a balloon filling up.
Right. And as it expands, these physical stretch receptors in the muscular wall of the bladder are activated.
They get stretched out.
Exactly. And that physical expansion triggers an electrical signal.
A ping.
A ping that has to travel up the pelvic nerves, navigate the entire spinal cord, and reach the pontine micturition center up in the brainstem.
That sounds like a really long journey for a tiny electrical signal.
It is, and that's just the first half. Then, the higher cortical centers of the brain have to actually receive that signal, interpret it as, oh, I need to pee, and simultaneously send a second inhibitory signal back down the spine.
To tell the body to wait.
Exactly. It sends a message saying, hold the sphincter tightly shut until we find a socially acceptable place to void.
It's this incredible long-distance two-way communication loop.
And here's the catch with younger kids. In a child under 5, the myelin...
Wait, what's myelin?
It's the fatty insulating sheath around those nerves. It's what allows electrical signals to travel quickly and efficiently.
Like the rubber coating on a wire.
Perfect analogy. In a toddler, that myelin is often still developing. It's incomplete.
So the signal is basically traveling over a bad connection.
Exactly. The signal might be weak. The brain's inhibitory response might be too slow. The wiring is quite literally still under construction.
So the kid might actually realize they need to pee, but the message to hold it doesn't get back to the bladder in time.
Precisely, which is why accidents are normal at that age.
But once you cross that 5-year mark, the expectation changes entirely, right?
It shits completely. By age 5, that neurological infrastructure should be robust.
The wiring should be finished.
Right. So if a child over 5 is repeatedly voiding twice a week for 3 months, it signals to the clinician that the issue is likely no longer just a developmental delay.
It prompts a full-on diagnostic investigation.
It absolutely does.
And this is where the detective work of a pediatrician really comes into play, isn't it?
It's the best part of the job, honestly.
Because the clinical notes we're looking at explicitly state that enuresis cannot be diagnosed if the voiding is directly due to a substance or another medical condition.
The differential diagnosis is critical here. You have to rule things out.
So if you are sitting in the clinic taking a history from this family, what are you asking?
You're asking highly targeted questions. For instance, you ask about their daily fluid intake. Are they drinking excessive amounts of water?
Because if they are, that could be what?
It could point to polydipsia or maybe even an underlying issue like early onset diabetes mellitus.
Oh, wow. Okay, so rule out diabetes. What else?
You ask about the physical act of urination itself. Is there dysuria?
Meaning pain?
Pain or burning when they pee? Yes, because that suggests a urinary tract infection.
Got it. Rule out a UTI.
And you also ask about their stooling habits.
Wait, poop. What did that have to do with bedwetting?
It's all about anatomy. Severe constipation can physically compress the bladder.
Oh, right. The colon gets too full and just squishes the bladder next to it.
Exactly. It severely reduces the bladder's capacity to hold fluid.
Okay, so as the doctor, you have to clear the field.
You do?
You ensure it's not a side effect of a diuretic medication, it's not a UTI, it's not diabetes, it's not constipation.
You isolate the enuresis as the primary issue.
Okay, but then looking at these clinical pathways, I saw something that completely stopped me in my tracks.
The secondary causes.
Yes, it's a causal chain for what the notes call a secondary cause of enuresis. And it starts of all places in the throat.
Ah, yes. The airway connection. What's fascinating here is...
Wait, let me just lay out the sequence from the notes first.
Go for it.
The sequence is, enlarged tonsils lead to obstructive sleep apnea, which then leads to deep sleep, which finally results in enuresis.
It's a wild chain of events.
You are telling me that a mechanical blockage in a kid's throat, just 2 enlarged pieces of lymphatic tissue, can literally cause them to wet the bed.
It is perhaps one of the most elegant, unexpected, and frankly frequently missed causal chains in all of pediatric medicine.
That is insane.
To really understand it, we have to look at the biomechanics of sleep.
Okay, let's walk through it step by step. First step, enlarged tonsils leading to obstructive sleep apnea, or OSA.
Let's start with the tonsils themselves.
Right. Tonsils are those lumps of immune tissue at the back of the throat. They fight infection, but sometimes they hypertrophy.
Meaning they just grow way too big.
Exactly. So what happens when a kid with massive tonsils goes to sleep?
Well, think about when you are awake. The muscles in your pharynx, your throat, they're active, they have tone.
They hold everything open.
Right, they create a rigid tube for air to flow smoothly down into the lungs. But the exact moment you fall asleep, your entire muscular system relaxes.
Which is usually fine.
Usually. But if a child has massive hypertrophied tonsils, that normal muscle relaxation is catastrophic.
Why?
Because of gravity and the negative pressure of breathing in, those massive tonsils just fall backward.
Oh, no.
They physically touch in the midline of the throat. The airway just collapses.
The pipe is completely blocked.
The child attempts to draw a breath. The diaphragm pulls down powerfully, but absolutely no air enters.
They're choking.
That is an apnea, a true mechanical obstruction.
So they are momentarily suffocating.
Yes.
And this brings me to the part of the causal chain that I really want to challenge, actually.
Let's hear it.
The next step in the note says obstructive sleep apnea leads to deep sleep.
Right.
Now, wait a minute. That makes no sense.
Why not?
If my airway is blocked and my oxygen levels are dropping, my brain shouldn't plunge into a deep sleep.
What should it do?
It should sound every alarm bell it has. It should pump me full of adrenaline and wake me up in a sheer panic so I can take a breath. How does suffocating lead to deeper sleep?
That is the exact paradox that confuses so many people, including a lot of medical students, actually.
See? I'm not crazy.
Not at all. And you're right about acute suffocation. That absolutely causes a panic arousal. You'd wake up gasping.
Exactly.
But we're not talking about an acute one-time event here. We are talking about severe, chronic, obstructive sleep apnea.
Chronic meaning it happens a lot.
This child's brain has been dealing with this airway collapse dozens, maybe hundreds of times a night.
Oh, wow.
Every single night for months on end.
So the brain adapts to the trauma.
It is forced into a state of extreme physiological triage.
Triage.
Yeah. Normally, sleep is supposed to cycle. You go through light stages, deep restorative stages, REM sleep. Right?
Normal sleep cycles, yeah.
But in chronic OSA, that normal sleep architecture is completely shattered. The brain is constantly being starved of oxygen, and it's building up toxic levels of carbon dioxide.
Because the air isn't moving out either.
Exactly. So, in a desperate evolutionary bid just to survive, to lower the brain's massive metabolic demand for oxygen, it abandons normal sleep cycling.
It just gives up on regular sleep.
It forces the child into an abnormally heavy, almost unarousable, comatose-like state of sleep between the apneas.
Wow. Okay, so when the medical notes say deep sleep, they don't mean a healthy, restorative, waking up feeling refreshed deep sleep.
Not even close.
They mean like a pathological bunker lockdown.
A bunker lockdown is the perfect analogy.
The brain is basically saying we are critically low on oxygen, shut off all non-essential cortical functions immediately to preserve the brainstem.
The brain has finite resources during these apneic episodes, right? So it reroutes everything to simply keeping the heart beating and attempting to force the airway open.
Which brings us to the final link in the chain. Enuresis.
The bedwetting.
Right, because in a normal kid, the bladder fills up in the middle of the night, the stretch receptors fire, the signal travels up the spine.
The whole loop we talked about.
Yeah, the brain gets the ping. Hey, bladder's full. Wake up.
But in the child with enlarged tonsils?
The brain is in bunker mode.
Yeah.
It's fighting a literal life or death battle for oxygen every 2 minutes. So the bladder sends the I'm full signal, and the brain simply drops the call.
It doesn't even process it.
It's like calling a 911 dispatch center during a massive hurricane and asking them to fix a pothole.
That's exactly it. The signal arrives at the cortex, but the arousal threshold is so artificially high due to the oxygen deprivation that the brain just refuses to wake the child.
It completely ignores the somatic input from the pelvis.
Right. And so the bladder just continues to fill. The physical pressure eventually overcomes the muscular tone of the urethral sphincter.
And the child voids in their sleep.
Without ever waking up.
That is absolutely profound. Think about the implications of that for a family.
It's huge.
You have parents who are exhausted, They're frustrated. They're maybe implementing behavioral charts, restricting fluids before bed, setting alarms to wake the poor kid up at 2 a.m.
Trying everything they can think of.
because they think it's a bladder issue or a psychological issue. But the entire time, the bedwetting is merely a symptom.
Just a red flag.
The actual crisis is happening inches away from the brain, up in the throat.
And this highlights the absolute necessity of a thorough physical examination. A clinician investigating enuresis can't just look at the pelvis.
What should they do?
They must ask the parents, does your child snore? Do they gasp for air at night? Are they excessively sleepy during the day?
Checking for the OSA.
Exactly. And they must physically look inside the mouth. Because if they open that airway and see tonsils the size of golf balls nearly touching in the back of the throat,
The entire diagnostic pathway completely shifts.
instantly,
Because if you send that child to an ear, nose, and throat surgeon, and they perform a tonsillectomy,
the mechanical blockage is physically removed, the airway stays open at night.
and the blood oxygen levels remain stable.
Right. The brain realizes it is no longer suffocating. It comes out of bunker lockdown, and the sleep architecture normalizes.
And suddenly, the brain starts answering the phone again when the bladder calls.
It really does. In many cases of secondary enuresis caused by OSA, the bedwetting resolves almost immediately following recovery from the surgery.
That is incredible, and it perfectly illustrates why we cannot look at the human body as a collection of isolated silos.
Oh, absolutely not. It's one system.
The plumbing of the bladder is governed by the electrical wiring of the brain, which is entirely dependent on the oxygen supply dictated by the anatomy of the throat,
It is one vastly complex, interconnected machine.
which is honestly an ideal vantage point to pivot here.
Yeah.
Because we need to move from the macro to the micro.
Yes, down to the cellular level.
Right, because to truly understand how this interconnected machine manages fluids, whether it's slowly filling a bladder overnight or rapidly bleeding out in a trauma bay, we have to look at where the fluid is actually controlled.
Down inside the kidney.
Okay, let's go there. We are shrinking down and entering the kidney. And I have to say, the clinical diagrams for this part of the notes are wild.
They can be a bit overwhelming at first glance.
When you look at a schematic of a renal tubule, it doesn't even look like biology. It looks like a blueprint for a massive hyper-industrial chemical processing plant.
That's a very fair assessment.
There are arrows everywhere, chemical symbols crossing barriers, energy exchanges happening left and right.
Well, the renal tubule is the fundamental functional unit of the kidney. You have roughly 1 million of these microscopic tubules called nephrons in each kidney.
1 million in each one.
Yes, and their job is monumental. They must filter your entire blood volume dozens of times a day,
Dozens of times.
deciding molecule by molecule what to keep and what to throw away.
Okay, let's try to visualize this factory floor for you listening. I want to build an analogy here to make sense of all these arrows.
I love a good analogy.
Let's imagine the bloodstream is a massive municipal water grid, bringing fluid directly to this factory.
Okay, the blood is the water grid.
And inside the factory, the cells lining the tubule itself, you have a very specific environment you desperately need to maintain. And the most important characters in this environment are two specific ions.
Sodium and potassium.
Right. Sodium, which is Na plus and potassium, which is K plus R.
The balance of those two ions is literally the foundation of all human cellular life.
So let's cast them in our analogy. Inside the factory, potassium ions are your essential workers.
Good guys.
You want them inside. They keep the machinery running smoothly.
Sodium ions, however, are troublemakers.
Definitely the bad guys in this scenario.
They belong outside, out in the municipal water grid, creating pressure. You do not want them hanging around inside the factory floor.
The problem, though, is the physical nature of cell membranes. They are slightly leaky.
They leaky.
Yeah. Sodium, drawn by a massive concentration gradient, is constantly trying to sneak from the bloodstream into the cell.
The couple makers hopping the fence.
Exactly. And potassium, for the same reason, constantly leaks out.
The workers are wandering off the job.
So if you just leave the factory alone, eventually it completely fills up with troublemaking sodium, all your essential potassium wanders away, and the factory shuts down.
It would be disastrous. So to stop this, you need security.
You need a bouncer.
A bouncer. And in the clinical diagram we're looking at, this bouncer is labeled as the sodium-potassium ATPase pump.
That is a mouthful.
It is, but physically, that pump is an intricately folded protein embedded right in the wall of the cell membrane.
And it has an incredibly specific, relentless job.
What does a bouncer do?
It physically grabs 3 sodium troublemakers from inside the factory and forcibly throws them out into the street.
And at the exact same time,
Simultaneously, it grabs 2 wandering potassium workers from the street and pulls them back inside.
3 sodiums out, 2 potassiums in.
Over and over and over again, billions of times a second.
The mechanics of that exchange are actually crucial. Notice the uneven trade there.
Uneven. What do you mean?
3 positive charges are thrown out, but only 2 positive charges are pulled in.
Oh, wow. I didn't even think about the math of the electrical charges.
It's the key to the whole system.
If you are constantly throwing out 3 positives and only taking back 2 positives, the inside of the cell is going to become slightly negative compared to the outside.
That is the resting membrane potential.
Okay, so it's an electrical thing.
By maintaining that uneven exchange, the pump literally creates an electrochemical battery. The inside of the cell is negatively charged.
And why does that matter?
Because this electrical gradient is the power source that drives almost every other transport mechanism in the kidney.
The bouncer creates the electricity to run the factory.
Essentially, yes.
But our bouncer doesn't work for free.
Right.
Moving ions against their natural flow, throwing sodium out into an area that is already packed with sodium, that takes immense physical effort.
It requires energy, specifically chemical energy in the form of ATP, adenosine triphosphate.
ATP is the currency of the cell. In the diagram, you see an arrow showing ATP converting to ADP.
Yes.
That represents the pump spending $1 of energy, basically.
Yeah. The ATP molecule is broken down, and it releases this burst of energy that physically changes the shape of the bouncer protein.
It flexes.
It flexes, throwing the sodium out and pulling the potassium in.
Consider the scale of this for a second. These pumps are operating in millions of tubules, nonstop, from the moment you are born until the moment you die.
A staggering percentage of all the food you eat, all the calories you burn while sitting perfectly still, goes solely toward funding this microscopic bouncer.
Just to keep the sodium out and the potassium in.
Because if the ATP runs out and the bouncers quit,
What happens?
the gradients collapse. Sodium floods into the cell, and where sodium goes, water inevitably follows due to osmosis.
The water rushes in.
The cells of your kidney would swell with water, burst open, and die within minutes.
So this pump is the literal baseline of life.
It really is.
And because this pump creates that electrical battery you mentioned, the rest of the factory can do its job, which is essentially mass recycling.
Let's talk about the glomerulus. It's the filter at the very start of the tubule, and it is incredibly inefficient by design.
Inefficient? How so?
It just dumps everything from the blood water, glucose, amino acids, bicarbonate, waste products. It dumps all of it onto the tubule's conveyor belt.
It just empties the truck onto the floor.
Yes, but you obviously don't want to pee out all your water and all your blood sugar.
Right, you die.
Exactly. So as that fluid travels down the tubule, the cells use the electrical battery created by our bouncer to power secondary pumps.
Okay.
These pumps furiously grab the glucose, the bicarbonate to manage your acid-base balance, and precisely the right amount of water, and yank them off the conveyor belt.
And throw them back into the bloodstream.
Yes, reclaiming the good stuff.
Leaving only the excess acid, the toxins, and the surplus water to roll off the end of the belt and head to the bladder as urine.
It is a masterpiece of dynamic sorting.
It is.
Yeah.
And the clinical notes actually give us a metric for how well this whole factory is running. It says normal GFR kill 90%.
GFR stands for glomerular filtration rate. It is the volume of fluid filtered from the kidney's capillaries into the tubules per minute.
So when we say a normal GFR is greater than 90%, what are we actually confirming?
We're confirming that the pressure in the municipal water grid is strong, the filters are intact, the conveyor belts are moving at the correct speed, and the ATP-powered bouncers are fully funded and operating optimally.
It is the picture of microscopic health.
The system just hums along perfectly while the child sleeps.
But this is this entire elegant factory relies on one massive assumption, doesn't it?
What's that?
That the municipal water grid is actually full. It relies on the presence of adequate blood flow to deliver the oxygen required to make the ATP to pay the bouncers.
Which brings us to the precipice. What happens when the water grid runs dry?
This is where we leave the microscopic world of cellular health and we crash violently into the macro world of clinical shock.
Let's go back to that emergency room.
The 5-year-old child who was just rushed through the doors.
The clinical notes transitioned here to the protocols for pediatric fluid resuscitation. They lay out a very specific scenario for us to follow.
Right. It says, for a child in shock, For example, 16 kilograms, 5 years.
Let's visualize this patient.
Okay, 16 kilograms. That's roughly 35 pounds.
A standard, average-sized kindergartner.
But they are in hypovolemic shock.
Hypovolemic meaning low volume.
They have lost a catastrophic amount of fluid. Where'd it go?
Well, maybe it's from days of severe gastroenteritis, relentless vomiting and diarrhea, or maybe it's hemorrhagic shock from a traumatic injury.
They're bleeding out.
Exactly. The origin of the loss dictates the specific treatment later on, but the immediate physiological crisis in that ER bay is identical.
Which is what?
The volume of fluid in the blood vessels has dropped so low that the heart, no matter how fast it pumps, cannot generate enough pressure to push oxygenated blood to the brain and the organs.
It's pumping empty space.
Basically.
If we look at our factory analogy, the municipal water grid is suddenly empty. The pipes are running dry.
Which means the oxygen stops arriving at the kidney cells.
And when the oxygen stops, the ATP production halts.
The bouncers freeze.
The cellular batteries die, and organ failure is imminent.
In this highly critical state, a doctor does not have time to run extensive lab panels to determine exactly how many milliliters of water the child has lost.
You can't wait an hour for blood work.
No, they need a rapid, highly accurate clinical heuristic to immediately begin saving the child's life.
And the notes give us that golden rule. It's the bedrock assumption of pediatric resuscitation. It states very simply, deficit equals 100 milligills a gram.
When a child presents in severe decompensated shock, the standardized medical assumption is that they have lost exactly 100 milliliters of fluid for every single kilogram of their body weight.
Let's do the math exactly as the trauma team would. We have a 16-kilogram child.
Right.
The deficit is 100 milliliters per kilogram.
So 16 times 100.
16 multiplied by 100. That equals 1,600 milliliters.
1.6 liters of fluid.
1.6 liters. That number it's staggering when you really think about it.
Yeah. It is a massive amount of volume for a child.
Imagine a large 1.5-liter bottle of smart water. Just picture that sitting on a table. Now look at a tiny 35-pound 5-year-old.
Yeah.
That entire bottle of fluid has literally vanished from their circulatory system.
Just to put that in perspective, a child's total blood volume is only roughly 75 to 80 milliliters per kilogram.
Wait, really?
Yes. So a 16-kilogram child only has about 1.2 liters of actual whole blood in their body.
So their deficit is bigger than their entire blood volume.
Yes. When you calculate a 1.6-liter total body fluid deficit, you realize the profound level of dehydration spanning the blood plasma, the interstitial fluid between the cells, and the intracellular fluid itself.
The body is entirely desiccated, like a raisin.
Precisely.
So the tank is empty. Now, my immediate instinct, if I am looking at a child who is dying because they are missing 1.6 liters of fluid, is to grab a 1.6-liter bag of IV saline, squeeze the bag, and blast it all into their veins as fast as humanly possible.
Just fill them up.
Yeah, refill the tank immediately to save the factory.
That is the most common intuitive trap in medicine. And honestly, if you followed that instinct, you would likely kill the child.
Wait, what? Explain that to me. Why is refilling the empty tank lethal?
Let's upgrade our municipal water grid analogy. The grid has run completely dry.
Right.
The main pumping station, the heart, is frantic. It is spinning at maximum RPMs, trying to build pressure with no water.
It's redlining.
Exactly. So it's overheating, the valves are strained, the electrical pacing is erratic. Furthermore, because the pipes have been dry, the delicate capillary networks in the lungs and organs have become leaky and compromised.
The infrastructure is incredibly fragile.
It's crumbling. So if you suddenly open the floodgates and blast 1.6 liters of fluid into that system at maximum pressure,
Oh, I see.
the compromised heart cannot handle the sudden, massive increase in volume. It cannot pump it forward efficiently.
It backs up.
The fluid backs up immediately. It hits those leaky, compromised capillaries in the lungs, and the water pushes straight through the walls into the air sacs.
Pulmonary edema.
You literally drown the child from the inside out. You overload a system that is too weak to process the very thing it needs to survive.
That is terrifying. It's like pouring a bucket of water into a stalled engine.
Exactly right.
So you have to walk this impossible tightrope. You have to give them fluid to save the cells, but you can't give them too much or you blow the pipes.
It requires extreme discipline.
Which brings us to the actual protocol in the notes, the immediate intervention. The notes say 30 milliliters equals 480 milliliters. To correct shock, reassess.
This is the initial fluid bolus, the vanguard of the rescue operation.
Okay, let's do the math here. 30 milliliters multiplied by 16 kilograms. That equals 480 milliliters.
Correct.
So out of the 1,600 milliliters they desperately need, you only give them 480 right now. That's essentially the volume of a standard disposable water bottle.
You administer that 480 milliliters rapidly, usually over 10 to 20 minutes. And the goal of this specific bolus is not to rehydrate the child.
It's not.
No, it is not to replace the deficit. The notes clearly state its singular purpose, to correct shock.
So it's a localized rescue mission just for the cardiovascular system.
Precisely. You are giving the heart just enough fluid volume to have something to push against.
You're priming the pump.
Exactly. You are aiming to elevate the blood pressure just enough to restore blood flow to the brain, the coronary arteries, and the kidneys.
You are restarting the municipal pump carefully, giving it just enough water to cool down and stabilize without overwhelming the leaky pipes in the lungs.
That's it, exactly.
You give the 480 milliliter to get the oxygen flowing back to the kidney factory so the ATP can be produced so the bouncers can start working again and stop the cells from dying.
Yes.
And then the notes give a critical instruction. Reassess.
You don't just hang the bag and walk away to the next patient.
You push the 480 milliliters, and then you stare at the monitors.
You check the capillary refill on the child's finger. Does the color return quickly?
You listen to the lungs with your stethoscope to ensure no fluid is backing up.
You watch the heart rate to see if it begins to slow down from its frantic, tachycardic pace.
You are looking for a physiological sign that the engine has caught a spark and is idling on its own again.
It's an incredibly tense few minutes.
Which brings us to what I consider the masterpiece of clinical mathematics. Section 4. The fluid maintenance puzzle. Let's assume the child responds beautifully to the bolus.
Okay, a good outcome. The blood pressure stabilizes.
The immediate threat of death is paused. Now, the medical team has to map out the next 24 hours of recovery.
They have stabilized the crisis, yes. But remember, the child is still massively dehydrated.
Right. The puzzle is how to safely infuse the remaining fluid over the course of a full day.
The notes lay out the raw materials for this puzzle perfectly.
First, we calculate the remaining deficit. We needed 1,600 milliliters total, right?
Yes, the 100 per kilo.
And we just successfully pushed 480 milliliters in that first rescue bolus. So 1,600 minus 480 leaves us with a remaining deficit of 1,120 milliliters.
That is the fluid that was lost before the child ever arrived at the hospital. But the math doesn't stop there, because a living organism is not a static container. It's not a glass of water.
Right. And here the notes introduce a new number, completely separate from the deficit. It says, maintenance fluid equals 1,300 milliliters.
A critical concept.
I want to really dig into this number for a second.
Yeah.
Why does a 35-pound kid lying perfectly still in a hospital bed need 1.3 liters of fluid just to exist for a day? Where is that water going if they aren't peeing or sweating?
It is lost to the invisible mechanics of being alive, which is known clinically as insensible fluid loss.
Insensible meaning we can't sense it.
Right? You can't easily measure it. Think about your own body right now. Every single time you take a breath in, your lungs have to humidify that air.
Oh, true.
When you exhale, you breathe out a massive amount of water vapor.
Like breathing onto a cold window pane and seeing the condensation.
Exactly. That is water physically leaving your circulatory system with every single breath.
And if a child is sick, they might be breathing faster, losing even more vapor.
Exactly. Then you have transepidermal water loss. Even if you aren't actively sweating, microscopic amounts of water are constantly evaporating right through your skin to regulate your core temperature.
I never thought about that.
Furthermore, the kidneys, even when massively dehydrated, must produce a tiny, highly concentrated mace-line amount of urine just to excrete the daily toxic byproducts of cellular metabolism.
They have to take the trash out.
Right. So the body is essentially a leaky bucket.
Even while you are trying to refill it, water is constantly weeping out through the lungs, the skin, and the kidneys.
The 1,300 milliliters is the precise calculation of that daily leakage for a 16-kilogram child.
Okay, so therefore, the medical team has two distinct jobs running in parallel.
Yes. Job A replaced the 1,120 milliliters of the historical deficit.
And Job B simultaneously replaced the 1,300 milliliters of ongoing daily maintenance loss.
So we have a total of 2,420 milliliters to give over the next 24 hours.
Now, a novice might just look at that, divide the total by 24, and set the IV drip at a constant rate of about 100 milliliters an hour.
Nice and easy. But the notes present a radically different, highly choreographed formula.
It's not a flat rate at all. The day is split into two asymmetrical phases. The first 8 hours and the subsequent 16 hours.
Let's analyze the formula for the first 8 hours. The clinical instruction reads 12 deficit plus 13 maintenance plus 560 plus 433 equals 993 milliliters in 8 acres.
Okay, I need to parse the fractions here. Let's take it slow.
Go ahead.
In the first 8 hours, you give half of the remaining deficit. The remaining deficit is 1120. Half of that is 560 milliliters.
Correct.
And you add 1/3 of the daily maintenance fluid. The daily maintenance is 1,300. 1/3 of that is roughly 433 milliliters.
All right.
You add them together, 560 plus 433, and you get 993 milliliters.
All right.
And that gets infused over the first 8 hours.
Now let's look at the second phase, the remaining 16 hours of the day. The formula shifts.
Okay, the notes read 12 deficit plus 23 maintenance plus 560 plus 866 equals 426 milliliters in 16 acres.
So let's break that down too.
Okay, so we give the other half of the deficit, the remaining 560 milliliters.
Yes.
And we give the remaining 2/3 of the maintenance fluid. 2/3 of 1,300 is roughly 866.
Exactly.
560 plus 866 equals 1,426 milliliters. And that volume is to be infused over a much longer 16-hour window.
Yes.
I remember looking at these fractions on the slide and thinking it was just, I don't know, arbitrary medical dogma, just numbers to memorize for a test.
It looks like it, doesn't it?
But when you map it against the physics of time, the brilliance of what they are doing here is breathtaking.
It is a true masterpiece of fluid dynamics applied to human biology. Let's break down the logic of the time split first.
Okay, the day is 24 hours long.
Right.
The first phase is 8 hours. 8 is exactly 1/3 of 24.
Yes.
The second phase is 16 hours. 16 is exactly 2/3 of 24. So the time itself is split into clean thirds.
Now, observe how the maintenance fluid is handled across that exact time split.
Let's see. In the first 8 hours, which is 1/3 of the time, we give exactly 1/3 of the maintenance fluid.
Uh-huh.
In the next 16 hours, which is 2/3 of the time, we give exactly 2/3 of the maintenance fluid.
What does that mean?
They match the fractions perfectly, which means the rate of the maintenance fluid is completely flat. It is a steady, unchanging drip across the entire 24 hours.
And physiologically, why does that make perfect sense?
Because the insensible fluid loss, the breathing, the evaporation from the skin, that happens at a constant, steady rate all day long.
You lose water evenly, so you replace that baseline water evenly. It's beautiful.
It really is. But the real genius is how they handle the deficit fluid.
Yes, the deficit is not split into thirds to match the time.
No, it's split exactly 50-50. Half the deficit goes into the first 8 hours, the other half goes into the next 16 hours.
Think about the impact of that.
You are taking 50% of the massive rescue fluid and aggressively squeezing it into only 33% of the time.
You are front-loading the recovery.
You're giving the cardiovascular system a massive surge of help early on when the body is still reeling and vulnerable from the shock.
You refill the tank aggressively while the danger is at its absolute highest.
And then, for the last 16 hours, you significantly slow down the rescue phase, letting the kidneys gently catch up and stabilize those cellular factories we talked about.
You achieve rapid cardiovascular stabilization without risking the lethal pulmonary edema we discussed earlier.
It is calculated, aggressive early intervention blended seamlessly with steady baseline support.
It's like finding a sinking ship, honestly.
Oh, I like this. How's
You patch the hull, right, and then you furiously pump out 50% of the floodwater in the first hour to guarantee the ship won't sink.
Right, get it out of the danger zone.
Once the ship is riding high in the water again, you can take your time and pump out the rest of the water over the next 2 hours, all while steadily passing out normal rations of drinking water to the crew.
That is a phenomenal analogy. It captures the dual mandate of resuscitation perfectly.
Thank you.
But as elegant as this mathematics is on a whiteboard, we have to acknowledge the messy reality of clinical medicine.
Always. Biology is not a textbook.
Patients do not always read the formulas. Which brings us to the final and undoubtedly the most complex section of these clinical notes. Section 5, dynamic reassessment.
Yes, things don't always go to plan.
Because the entire math formula we just built, the 8 hours, the 16 hours, it all relies on the assumption that the very first 480 milliliter bolus actually worked.
That it successfully corrected the shock.
But the notes include a glaring warning right in the middle of the equations. Reassess every 2 to 4 agers.
Because what happens if you push that initial 480 milliliters, you stare at the monitors, and nothing happens?
The nightmare scenario.
The heart is still racing, the blood pressure is still catastrophically low, the child is still in shock. The initial prime wasn't enough to restart the engine.
And this is where the shorthand of the clinical notes gets incredibly cryptic. I'll admit, I stared at this final bullet point for 20 minutes trying to make the algebra work.
It's famously confusing for students.
It reads, NB, if after reassessing it and child is still in shock, repeat it. Shock, After 100 millikilograms, 30 millikilograms, plus 30 milligrams, plus 30 millikilograms, or 130, 20, 50 millikilograms.
To a layperson or even a math teacher, that first equation looks like utter nonsense.
It does. 100 minus 30 is 70. 70 plus 30 is 100 again.
Yeah.
Why on earth does the slide conclude that it equals 40?
I've seen students pull their hair out over this.
I was completely lost.
Mm-hmm.
But then I realized this isn't pure math. It's a chronological narrative written in math symbols.
Ah, you cracked the code.
The plus and minus signs represent physical actions taken by the doctor over time. Let's decode the story here for the listener.
Walk us through the timeline of that first equation.
Okay, the child arrives. We establish the total systemic deficit is 100 milliliters per kilogram. That's our starting line.
Right.
The doctor orders the first bolus. They physically push 30 milliliters per kilogram of fluid into the child.
That physical action is represented by the first main of 30. You have chipped away at the total deficit.
Exactly. You've paid down the debt a little. But they reassess, and the child is still crashing. The first bolus failed to reverse the shock.
So the doctor gives a verbal order. Repeat it.
They push a second bolus of 30 milliliters per kilogram.
And that second physical intervention is represented by the plus 30 millikilogram in the note.
So the plus sign doesn't mean mathematical addition to the starting number.
No, it translates to, and then, in addition to the first bolus, we administered another bolus.
Okay, so let's step back and look at what we've actually done. We gave the first 30, then we gave the second 30. We have successfully pushed a total of 60 milliliters per kilogram of fluid into this child's veins.
Now, return to your original target.
The original target deficit was 100. We have forcefully infused 60. 100 minus the 60 we've already given leaves us with exactly 40 milliliters per kilogram of deficit remaining.
There is your 40 millikilogram.
It's so obvious once you see it.
The shorthand 100 to 4 plus 30 equals 40 is just a highly compressed narrative. Start with 100 deficit. You gave 30. It wasn't enough, so plus you had to give another 30. You have now administered 60 total. Therefore, when you sit down to calculate the 24-hour maintenance math, your starting deficit bucket only has 40 millicure left in it.
Once you see it as a story, it makes perfect sense. And that logic immediately decodes the second alternate equation, or 130, 20 equals 50 millikilogram.
Let's explore the clinical reasoning behind that alternate reality. Why might a doctor choose those specific numbers?
Let's imagine this scenario in the room. You give the first 30 millikilogram bolus, you reassess. The child's blood pressure comes up a tiny bit.
They are still in shock, but they aren't crashing quite as hard.
The doctor knows they need more fluid to fully prime the pump, but they look at the child's chest. Maybe they are breathing a little heavy.
The doctor is terrified of the pulmonary edema we talked about. They don't want to hit the fragile system with another massive 30 millikilogram wave.
So they titrate the intervention, they step down the dose.
Yes.
They order a more cautious second bolus of 20 milliliters per kilogram. So the math story becomes, we started with a 100 deficit, we gave the first 30, we cautiously gave a second bolus of 20.
30 plus 20 means we have infused 50 total.
And 100 minus the 50 we gave leaves a remaining deficit of exactly 50 milliliters per kilogram to be plugged into the 24-hour formula.
It demonstrates that protocols are guidelines, not suicide pacts.
That's a great way to put it.
The physician must remain at the bedside, interpreting the raw data of the human body in real time. If the lungs sound wet, you pull back. If the pulse is still thready, you push forward.
The equations expand and contract based entirely on the moment-to-moment physiology of the child.
It's the ultimate fusion.
You have the rigorous, unyielding science of fractional mathematics being wielded with the nuanced, highly subjective art of clinical observation. Intervene, measure, recalculate, over and over until the child is safe.
And that cycle of continuous recalculation is what ultimately allows the medical team to hand control of the system back to the child's own body.
To get the cellular factories funded and the bouncers working again.
Exactly.
And what an incredible full circle that is. We have traversed an immense landscape of medical knowledge today, all from a single page of clinical notes.
We truly moved from the macro to the micro and back again.
We did. We started with the ancient Greek definition of enuresis. We uncovered how the mechanical physics of an obstructed airway and large tonsils can force a child's brain into a desperate, oxygen-starved bunker lockdown.
Completely severing the neurological connection to the bladder and causing secondary bedwetting.
Then we examined the microscopic architecture of the kidney. We visualize the sodium-potassium ATPase pumps, the bouncers furiously burning ATP to maintain the delicate electrochemical gradients.
The gradients that allow the entire renal factory to sort, recycle, and filter our blood.
And finally, we stepped into the chaos of the emergency room. We learned the 100 milliliter per kilogram deficit rule.
We calculated the precise fractional math required to aggressively front-load a life-saving rescue bolus.
All while simultaneously managing the invisible, steady loss of daily maintenance fluid.
It is a profound testament to the complexity of the human machine.
It really is. And as we conclude this deep dive, I want you, the listener, to take a moment to reflect on your own body right now.
Consider the sheer resilience and the quiet, miraculous automaticity of the biology you inhabit.
We spend so much time taking it for granted.
We really do.
We've spent an hour exploring how precise and, frankly, how fragile our internal fluid balance is. We've seen how easily a millimeter of enlarged tissue in the throat can disrupt the hormonal signals of the bladder.
Or how walking the tightrope of a fluid bolus can mean the difference between life and death.
Exactly. We've walked step by step through the agonizing high-stakes calculus required by a team of doctors to manually fix a circulatory system that has crashed into shock. It requires immense, highly educated intervention to fix the machine when it breaks.
But the corollary to that fragility is an incredible innate competence.
Yes. Here is the thought I want to leave you with. For the vast, overwhelming majority of your life, you don't need a team of doctors standing over you.
You really don't.
Because those microscopic cellular pumps, those millions of little bouncers lining your renal tubules, they are managing this complex calculus automatically.
They are burning the ATP, they are balancing the positive and negative charges.
They are adjusting the filtration rate of the municipal water grid every single second of every single day.
The breathtaking mathematics that we just spent an hour decoding on a whiteboard is being solved by your cells, flawlessly.
Without you ever having to consciously direct it. So later today, when you go to the kitchen and take a drink of water, just pause for a second. Think about the incredible, relentless, microscopic mathematics happening behind the scenes to keep you perfectly, beautifully in balance.